my whole life. Went to UMHS, which is a Caribbean medical school, like 90 miles east of Puerto Rico. Was down there, really actually by chance, ran into Dr. Damage, which is a high-level faculty here down the street at one of the AFP conferences. So I talked to her and just really got a good vibe as far as the openness. Came up for an interview. And the thing that really struck me about this program is that it is a family in the sense that everybody here is super friendly. There's a big aspect on community medicine. So we have a garden outside that really piqued my interest. Like they actually like allow patients to come here, get free food. So there's resources there. They have a track outside. So essentially, you know, patients, if they want to exercise, they can exercise there for free. We actually do our own exercising classes here. So it just kind of was building on this like wellness aspect that they actually care and want to go out in the community and make changes. We do a lot of like home visits, stuff like that. So like, you know, as far as when you do it in your third year, if you want to do that, Nurse Jenny is amazing. She like, if you do get the opportunity to interview here, the first thing that you do is you go down and sit at the with Nurse Jenny and actually look at this book of pictures of all the stuff that they do in the community and have done in the past. And that like really struck me because like the first thing usually you talk about is, oh, here's our program. We do this at the hospital. We do this as far as rotations. Like their first thought was, hey, like let's make sure that everybody knows we're about the community. That really struck me really well. And I was living in Chicago, so it was a really convenient. Me and my wife love the city, so it was really close to there too. So that was another big selling point for me. And then the program itself, as far as if you're really wanting like an OB heavy, program, that this is, not the kind of program that I feel like that would be for you. So for me, I wasn't super interested in OBGYN. So this is one of the lighter programs that I interviewed at. So really for me, that piqued my interest as well. We do have 2 months in the first year, and you can do electives and stuff like that if you want to in the future. But for me, that was a really big selling point. And then really it was all about the energy. I mean, I came to the second interview as well and really, really loved the way that you interacted with people and just that genuine nature. And I can attest to even now, still feeling that really open energy, and you're never like in a position like, wow, I can't get help, or they're not going to help me out. As an intern, you're always, going to be asking a ton of questions because you really don't know much. Let's be honest. You have a good foundation in medicine, but as far as running a hospital or running a clinic, we're still babies kind of crawling around, and they're helping me crawl a little bit better now. Anybody have any questions?
Sorry, just wanted to interrupt really quick. I'm Jackson. I'm the third-year chief. I'm not really going to be answering questions unless the interns don't really know how to answer the questions. But I think next up is going to be Tom. I'll just let Tom introduce himself because I think Wallace got a page. So go ahead, Tom.
Hello, nice to meet everyone. My name is Tom. I'm originally from Iowa. I have family in Wisconsin. I'm a first-year intern here in the program. A lot of the things that Charles talked about are also reasons why I picked the program. When I was on the interview trail, I interviewed at quite a few programs, and this program was definitely the most community-oriented, or so that was my impression leaving it. And that was for a number of reasons, including the ones that Charles mentioned. Some of the things that I've kind of started to realize while kind of, being in medicine is that really we can only affect about 20% of what a patient's, we can only affect 20% of a patient's health. The rest is largely environment. And this program is kind of seeing medicine from a more global perspective, I think, in terms of its ability or its attempt to try to connect with people outside of necessarily just the clinic setting. And Charles talked about some of that. So this is why one of the large reasons why I have picked this program is because it allows us to interact with patients in a more holistic approach. And this is also, our clinic is also in an area of town that is under-resourced. So our patients are not necessarily going to be the same patients that are seen in other areas of Milwaukee. And I think that provides an opportunity to really impact a community. And I'd really like this clinic, this residency program's approach to that. I also think it can provide a great training experience. So yeah, that's kind of reasons for why I was excited about starting in this program. And actually, the first time I did discover this program was also at the AAFP, similar to Charles. So yeah.
Cool. I think as of right now, those are all the interns on right now. So we'll start answering questions. First one I got was, so Charles and Tom, what is the most challenging aspect as a first year that you guys have come across so far?
So I guess for me, it's been mostly like workflow related things, organization, EMR. It's stuff like that. It's kind of like it's this really, I don't know. So it's a huge learning curve with regard to just like kind of how to organize your day and workflow. It's kind of funny. It's like in the first, I feel like couple months, a lot of my time is spent kind of navigating the EMR and just kind of how to organize my day. I'm looking forward to the point where that stuff kind of becomes second nature, and I can think like more in depth about patients and medicine and stuff like that. But that's like probably the largest difference between medical school and intern year for me so far. And Wallace is back, just FYI, Jackson.
So Wallace is one of our Canadians. So I don't know if any of you guys' perspective are from Canada, but Wallace can talk a little bit about transitioning from Canada. So go ahead, Wallace.
Yep. Well, I'm actually from Toronto. Not sure how many of you guys are from there, but actually, I found the transition from Toronto to here in Milwaukee pretty smooth. Oh yeah, I see someone here is from Toronto too. Awesome. The Milwaukee, it is smaller than Toronto, but at least where I'm staying, it has a similar sort of energy. Lots of nice little places to go out to eat when coronavirus isn't a thing. Lots of the area that I'm in is quite diverse, which is nice, and it's by the water. So I'm really enjoying the city. It is a transition, of course, because I'm in a new country, different system. But I did find a lot of support amongst a lot of the other residents. There are quite a few Canadians in the program. So I've always found that there was someone I could reach out to get advice from, whether it's something as simple as, opening a bank account here in the States, or getting a car, that sort of thing. Like practical things were really helpful. And also about getting advice on whether or not I'd want to move back to Canada afterwards. There's a lot of people in the program who are going to be doing that. So I found the transition pretty good.
Nice. Thanks, Wallace. So back to our first question, which I think is really appropriate for the interns. What have you, Charles, and you, Wallace, have found the most challenging aspect as an intern?
So I'm married. So one of the biggest things that I've had to kind of learn how to do is juggling, working, I started off in medicine. So I was working really, really long hours and had to kind of balance work and life. It's completely doable. The key thing, if there's is anybody actually married at this point? Yeah. So, I think the big thing is just really having a good supportive partner and kind of prepping them for what's going to come, because you don't want to leave them thinking that it's going to be easy and I'll come home and we can hang out for hours. You're going to be tired. My wife is amazing. She, cooks food for me. She's running the whole house and just making it really, really easy on my life. I think really having that conversation before you start residency with your significant other that, hey, this is what's coming, and having that conversation and kind of having a game plan is really, really important. As far as the anything else, I think the what you should be looking for in a program is a foundation of teaching doctors, meaning that they want to help you learn and help you grow. If you feel some vibes in any program that you were interested in, that you feel like it's a little bit more they aren't going to always be there for you, then that's a red flag. And always really, when you do interview, make sure that you ask the residents and get their vibes on how they feel the program's running, because the upper level management's always going to tell you everything's great, this program's amazing. But really, I spent most of my time on interviews saying, hey, like, what's going on with the residents? How are they feeling? And if they're supportive? And here it's amazing. So the transition has been easy in that regard.
Yeah, I think for me, just the responsibility of being a doctor now has been a big transition from medical school, because I found in medical school, you might know the stuff, but again, the onus is all on the resident or the attending. But now, just that added responsibility and knowing that, like, okay, gotta, be on my game and make sure that I can treat the patients as well as I possibly can, has been a big transition. However, there is a lot of support. Even as far as being organized as an intern, making sure that, I have everything done and all my orders in a timely manner has been tough. But I found that there's been a lot of teaching. My seniors have been very, very supportive and helping me to make that transition and to be able to succeed in, my first few months of residency.
Nice. And right next to Charles Mitchell is Yelena. She's another one of our interns. So if you can just tell us a little bit about yourself, Yelena, and what do you think is the most challenging aspect of the first year?
Hi, everyone. So I'm Yelena. I'm originally from Wisconsin, Milwaukee, went to Serbia for med school, and I came back and was fortunate enough to start my residency here, hopefully complete it here. So the hardest thing for me, I don't know, it's just a big change, just having that responsibility and feeling like an actual doctor, which you are, and just making sure I manage my time. So making sure when I wake up, when I have inpatient, know when to get there, know what I'm doing, and just really going through the workflow was the hardest thing for me, I guess. But after a month, I feel fine with it. And from what I understand, most interns kind of go through that shock. But everyone is very helpful here, so I didn't feel more stressed than I should. But really, that was it, just managing my time and just getting used to that. But otherwise, everything else was really, really good so far, so I can't say anything else about that. I'm not the most eloquent person on the planet either, so I'm sorry.
Cool. Well, thank you for your perspectives. And so the next question we have is, what resources are available from MCW? I don't know if any of you guys the interns know as well as I would, but if one of you guys want to take a shot at it, you're more than welcome to. Go ahead. So I'm going to take the silence as a no. So it makes sense. As a third year, I've been here for 3 years, so I know what kind of resources they offer, whereas the interns are just trying to keep their head above water, which at the end of 3 years, I promise you'll swim greatly. But right now, it's just the beginning. So MCW is a great resource. Monetarily, I think MCW as residents, we get paid one of the best salaries in the States. I know when I started, it has gone up, but when I started, we got $60,000 a year. So that's not bad as a resident. Secondly, we do get $1,000 a year for CME money. So if you buy books, you buy iPad, you buy a laptop, they'll reimburse you for that. Another thing we get is $1,000 in loan repayment. I have loans that I'm slowly paying back during residency. One of them is Sally Mae. If I submit a receipt, they'll reimburse me up to $1,000. And those two are not taxed, so you get the full $1,000. The third thing that we get is $1,500 a year, but unfortunately that is taxed. That $1,500 goes to things as buying it's essentially a bonus on your check, 750 around Christmas time and 750 in June. And after taxes, it jumps to like maybe 500. But it helps because like to buy your DEA is 750 bucks, or to buy like your tests or anything like that. You don't have to submit a receipt for the 1500. That's just like a little bonus you get. As to like mental health and everything, MCW, they're like psychiatrists, they're psychologists. We are allowed to go on their campus and work out. We get together at their campus and we use their like simulation programs. Unfortunately, it's kind of cut down now because of COVID, but before COVID, we would go there at least once a month and work on like suturing, work on like all the family medicine residents would get together and work on certain things like geriatric, sports medicine, and things like that. So the MCW does give us a lot of resources, but they're not going to shove it in your face. We'll know about it, but it is up to us to go and use them.
Yeah, and I kind of just want to second on that. One of the biggest benefits with this program is the salary. I mean, it's right now for as an intern, it's $61,970, and the big thing that when I was on the interview trail, a lot of places are going to be high 40s, mid 50s, and that extra $5,000 to $6,000 is huge. I mean, especially if you've got a family, it really does come in handy and allow you to feel like you can have a comfortable life without, you're going to, regardless of where you go, you're going to work a lot. So, I mean, being able to have that little bit extra to be able to save, pay back loans, if you want to enjoy, like me and my wife go to Chicago sometimes, just to be able to enjoy life a little bit. It's really nice because you don't feel like, oh my God, I'm broke,
Yep. So yeah. And then just a little side note, Milwaukee's cost of living is nothing. I'm from Chicago, so moving to Milwaukee, traffic and cost of living, amazing. And I could feel the same about like I heard Toronto is pretty expensive, New York is ridiculous, things like that. So next, can you explain about the sports medicine and what point can you join the team physician and actually what do you do as an intern? I feel like unfortunately, intern year, you kind of get your schedule given to you. But you do work with the sports medicine doctor, so you really do get good at your MSK exam, but you don't get the opportunity to like be at the ballet because you're the team doc or hang out with the Bucks. If any of you interns have any other like takes on that, feel free to chime in.
Yeah, so I'm actually interested in the sports medicine track myself, and so that was a question I asked at every single place. So the great thing about this program is Dr. Gottschalk, who is the head team doc for the Bucks as well as doing the ballet. So being able to rub shoulders with somebody and pick their brain, and hopefully follow in the footsteps of being a great physician as far as this not only just family but sports med for me. So I know that the second year is when you actually can get your own team. So there's high school teams here. Dr. Gachos is well versed in the community. So just knowing that those options are available, you don't have to fight for anything, and the opportunities will be there second year. So I think you're going to sports med too. So Yelena could kind of chime in on her part.
Oh, I mean, you pretty much said everything. I agree with him. But yeah, if you're looking into sports medicine, that was one of the reasons I wanted to come here. It's a very strong. You have a lot of learning opportunities to set you up for fellowships if that's something you want to do. Or if you just have an interest, you can really learn a lot.
Fun fact, one of our chiefs, like 2 years ago, she was the first family medicine to match into sports medicine fellowship at MCW. And it helped because Dr. Goshlish is like the second in command. And Dr. Young, who is the head of the sports medicine fellowship, he comes to our clinic and we staff with them. So you can develop those relationships. And just a funny story that I had is, I don't know if any of you guys are big basketball fans. I'm not a huge fan, but I know like a year or two ago, Giannis kind of like messed up his knee. So Dr. Goshlish and Giannis are like texting buddies. So it's funny because she would tell us stories about how she would yell at him because even though he had a messed up knee, he would still try to like practice on it and things like that. And she would just text with them. So I thought that was kind of funny. But yeah, Dr. Gossage has pretty much all the numbers of like the Bucks team's players in her cell phone. And she'll in the middle of staffing, she'll stop, take a call from a player, yell at them, and then go back to staffing. It's pretty funny.
You can't yell at Giannis, though. It's a rule in the program. You got to be nice to Giannis.
Yeah, and also too, like it's Bucks Mania up here too. So like I'm a big basketball fan myself. So I've been heavily guided to be now a Milwaukee Bucks fan. So
next, how has COVID impacted the community programs? Any of you guys want to speak to that?
yeah, so I think the big thing that I've seen so far that the impact is a lot of the community aspects that we have in the program are not as functional in the sense that, because of all the restrictions that COVID has, a lot of the community-based aspects are not as available. The good thing is, people can still come into the clinic. Your duties as an intern are pretty much the same. The only thing I would say that, and as far as me, would be that, just making sure that you're taking the proper care, because when you go home, you're going to transfer that to your wife, your kids, or if you're just even by yourself. I mean, it's just taking that extra little bit of precaution. And it's one step that none of us have had to really take unless you were, still in medical school at the time where COVID hit.
Yeah, I agree with what Charles is saying. Who could have ever seen COVID coming? It's definitely, decreased our ability to interact with our patients on a more kind of complex level. A lot of our visits have also gone to telephone visits or virtual visits. So it's going to be really exciting next spring, summer. Hopefully, COVID is eased and we're back to our normal. So yeah, it's been hard on our outreach and community programs for sure.
Yeah, so just to talk about some of the things that we do as a community that are for our community programs that's been impacted by COVID. Every year we have to do 2 home visits. So you pack up a little bag, like back in the old days, you go with Nurse Jenny to a patient's home and you kind of visit them in their home, see what kind of setting they live in, what kind of foods they're eating. And you can bill that as an actual visit. So we've lost that capability, which sucks, because let's say you have a diabetic patient. What I've done with Nurse Jenny is go see one of my uncontrolled diabetics and kind of go through their pantry with them and be like, hey, this isn't good for you. Let's switch to this, or this isn't good for you. Or even just seeing the type of atmosphere they live in. Another thing that we've kind of lost is as a second and as a third year, you have to do a month of community medicine each. And that involves things as going to the local high school and talking to the kids, teaching the kids. So we haven't been able to do that because of COVID. Nurse Jenny is really into the community. So every Tuesday and Thursday, she would host workout programs or like yoga and meditation. We've kind of lost that as well. We started redoing that because during the summer, we've realized that we can kind of space out in our huge garden or huge backyard. So we've started working out again with things like that. So they're slowly coming back, but yeah, we kind of took a big hit on our community programs.
And our garden is still going.
Yeah.
So
I actually picked some of the tomatoes yesterday.
Yeah, nice. There's plans to expand that garden too into a greenhouse so that it can be more functional year round, which would be great.
So yeah, things like that. And then yeah, like Tom and Charles have talked about, we do have a garden, and it is sort of like a community program in that it is ran by the high school kids, so they get paid for doing it. But at the same time, we sell the food to like the local hospital, to St. Joe's. So when you eat at the cafeteria, it is a lot of food that came from our garden. At the same time, we also like to pick some of the food and give it to some of our patients are in need. So that's pretty awesome.
Our clinic did host a farmer's market last week as well. I think, I don't know if, Jackson, I don't know if you know more about that, but our clinic has hosted a farmer's market. I'm not sure quite how often it comes through, but it's like a farmer's market that rotates for different communities.
So that kind of bleeds into the next question, impact that we've had on the health disparities within the community. So I'll start off by saying that by the end of our third year, we have to do at least one health, like community health project. So I'll talk about that a little bit more, but I'll let the interns talk about what they feel like about the health disparities and what they're doing.
Yeah, so I mean, I think the big thing that I've noticed here at the clinic, which is amazing, is that the access to care, we can actually set up lift rides for our patients to and from, because a lot of the access socioeconomically is just being able to get to clinic. I mean, some people have to take 2 or 3 buses, you know, I mean, it's really arduous, and it actually turns away a lot of people in normal settings where there's a low socioeconomic threshold and within the community. So I think the ability for our patients to have transport through their insurance is amazing, because the actual show up rate within the clinic, and if they need to go to the hospital for outpatient labs or anything like that, there's a lot more access there. And I found that, you know, specifically in this environment, the key thing I want to make sure everybody, this is a community-based medicine program. So if you're going to want to work in like a large urban environment and you want to deal with people of the higher socioeconomic threshold, this isn't the program for you. But if you want to really make an impact on a lower socioeconomic group of people, this is amazing. And that's one of the big things that drew me to this program, was that I could help people that really don't have a lot of access or kind of pushed to the side in a lot of other situations.
Yep. So that very nicely, but yeah, I definitely agree with them. And you can really feel that when you're here, just trying to help out the community and increase access as much as possible. Yeah. And they really do it here. So it's not that they don't just talk it, they do it. So we all do. We try.
There's also psychological social work help in our clinic. And Jackson, what the original question was, how does the community health rotation, like what kind of, we haven't had the community health rotation yet. I think is that second or third year? Second, yeah.
So community health is 2 months. You do 1 month as a second year, 1 month as a third year, and that's the rotation where you work on your project the most. That's going to be the rotation where you talk to Nurse Jenny about what you would like to do, whether it's like a diabetes fair, which has been done, going to the local high schools and just talking to the kids, like, especially as a female, like, why do I want to be a female doctor? One of our third years that left last year, Dr. Hudani or Malika, she did a lot of that, and she got a lot of questions about what it is like being a female in the workforce. Unfortunately, it sucks because, let's be honest, females and males still aren't seen as equal. So she's had things whereas she'll come in as a senior, but people will think she's a nurse just because she's a female. And I'm sure that happens a lot, especially a lot of the female med students are soon to be female doctors. So how she's had to combat that, how she's had to deal with that. But
there's also a relationship that the clinic has with community leadership. And Jackson, I think you can probably talk more about this than I can. But it seems like our clinic has kind of found itself in this kind of oversight role in terms of trying to facilitate communication. We've talked a lot about our community. There's a high school not far from us that has a graduation rate of 40 to 60%. That does a lot. I mean, the illiteracy rate is roughly 10% in the community that we serve. So there's so much opportunity, I feel like in the community that we serve for growth and for better life. And it's proud. I feel proud to be a part of a clinic that realizes that and is working towards making that a reality. And Jackson, can you speak at all to that kind of that role of overseeing some of the communication that leadership has in our community? And I think we're a part of those conversations as well.
Yeah, so first off, speaking about that high school, yeah, part of your community medicine is you'll go there, you'll talk to the kids, you'll like educate them about the body systems and things like that. As for the community, the leadership roles, our clinic is what is known as a food desert. So part of the conversation we've had is building that greenhouse, building that garden, getting the farmers market to come. And the farmers market is like all the foods are high quality, but at a reduced price for everybody to come at. I don't know if you guys have heard of something called Imperfect Foods. It's this like, yeah, this monthly mail-in thing. Or I'm sorry, they mail you a box of food that is not pretty for the grocery stores at a reduced price. We have, I think, 12 to 15 families, and that was part of someone's community project. We have Dr. Kerndt, who's a third year. He's in charge of it, but he signed up 12 to 15 families that gets this box of like really good food at no cost to them. You just have to meet some standards, you know, and then, you know, they also follow up. You come in, you get your vitals checked, you get your weight checked, you get like your blood work checked just to see how this box of food is helping the family. We have a free legal bus that comes once every 2 weeks to a month. So anybody that has any legal questions, not like murders or rapes like that, but like, hey, my landlord is trying to evict me. What can I do? What resources can I use? Things like that. And it is ran by Marquette. So I don't know if you guys know Marquette. It is one of the bigger, fancier universities in Milwaukee. So that's a service that we've talked to them and they're providing to us. What else are we doing? Yeah, leadership, things like that. Oh, yeah, that's all I can think of off the top of my head.
Well, I know too, they host at the clinic, I think it's monthly or at least, quarter annually, where they actually have the community leaders come in and meet, and, we can have input as far as a clinic, as well as some of the leadership that runs the clinic. So we can make sure that we're constantly connected with what's going on actually in the community. So I know they do host an actual meeting throughout the year to make sure we're doing the right things with some of the city councilmen, the leadership as far as government within the city itself.
Cool. Next question. What are your long-term goals within the program? Which track would you like to be a part of? So we've heard about the sports medicine track. Anybody else want to chime in about other tracks?
Okay.
I'm not really thinking about fellowship personally. I'm looking forward to mostly a kind of broad spectrum type of practice. One of the things that I might consider later on, intern year is really, we've kind of touched on this, but there's not a lot of opportunities for individualizing the curriculum, not yet. But there are opportunities in the second and third year. So I'm looking forward to perhaps, I want like a general type of practice. I'm still kind of figuring it out myself. Doctors Without Borders or work like that is something that I'm interested in. Some public health is stuff that I'm interested in. In terms of how I'm going to tailor my experience here, I'm still figuring that out. But hey, it's month 2, so we'll see. Yeah.
Yeah, I think I'm fairly similar. Still trying to figure out which route to take, because in med school I was one of the ones who just liked everything, and I think that's carried through here too. So still trying to figure out how I want to tailor my program to my specific goals. But coming in, I was definitely interested in sports, kind of also interested in rural, very interested in serving the underserved. So I do hope to continue that, both throughout my time here and going on beyond.
Yeah, I think one of the big pluses that you should also be looking for in other programs when you do interview is how flexible is the second and third year. Because a lot of programs will, if you actually go through and each program will have what your actual schedule, availability as far as second and third year. Some programs are really, it's already set. One of the big benefits for here is you really can second, third year tailor to you. So the big tracks we have is the sports med, urgent care. Some people are actually going into internal medicine. So I know Jackson's going urgent care route. You can literally work in the ED afterwards. The availability to do a lot of stuff. Some people go into geriatrics. So there are springboards to allow you to have that really personalized, tailored experience for what you want to learn and who you want to be as a doctor, which is, what you would hope that every program has that, but it's not true.
Yeah, so my answer is kind of gonna blend this question and the next one about the procedures. So like Charles said, I am part of the urgent care track. The cool thing about the urgent care track is that the head of the ED, like emergency residency program, Dr. Mikowski, he kind of runs our urgent care track. So when you're working with them, you're not a family med doc, you're an emergency medicine doc. So you're doing everything. I've ran codes, I've done intubations, I've done art lines, central lines. What else have I done? In the clinic, one of our faculty, Dr. Damitz, she did an intern year as a surgery resident. And then she switched over to family med because she didn't like the surgery lifestyle, but she brought the surgeon skills. And just between us, sometimes she can be a little bit of a surgeon, if you guys get what I mean, but she's great. I love her. But she'll teach you how to do pretty much any procedures, lumps, bumps. So you can do cyst removals, you can do colposcopies, IUD placements, IUD removals, Nexplanon. So you do get a lot of procedures. It's not built into our curriculum, but as a second and third year, you do have a lot of electives to choose a procedure month, whether that's in the hospital or whether that's in the clinic.
One other thing I would just say about it is that we don't have a lot of competition between other residency programs in this program. There's transitional years at St. Joseph's, and they see people in the hospital, and there's an OB residency, but there's not an ER residency, and there's just a lot of opportunity for exposure due to the kind of in a sense it's like a rural program, being that there's not a lot of other residency programs, like say Freighter, for instance. So it provides opportunity because there are less residents in the facilities. Yeah.
Yeah, before Jackson goes to the next question, I think one of the things that I would recommend people to pay attention to is whether or not it's you'll be working alongside other residency programs. Sometimes there can be some like butting of heads in nature, as far as like, say you're working with a team, it's like competitive versus non-competitive. So this is completely non-competitive. So I mean, like, we run our whole team and we run the clinic by ourselves. So you feel like it's more like you have a lot more control in that aspect, and you don't have to worry about competing against any other residency programs.
True. And at St. Joseph's is where we do our inpatient. So let's step back a little bit. Children's Hospital of Wisconsin, unfortunately, it is competitive because it is the big children's hospital. So there's pediatric residencies there, unfortunately. There are EM residents that rotate through there, but they don't treat us any differently than they treat any of the others. When you're on children's inpatient, they work you like a PEDS resident. They don't care that you're family med. When you're doing the children's emergency medicine, they treat you like a pediatric emergency medicine resident. Yeah, so you're doing everything. At St. Joe's, where we do adult medicine, there is a TY team, a transitional year team, but the hospitals love working with us. So I'll be honest, our census, most of the time, I want to say it's 90% hospitalist patient and more like 10% our clinic patient. I think that's because we do an awesome job taking care of our clinic patients so they don't show up. But the hospitalists do love admitting to us. So even if you think it's going to be a good night, you always got to be weary, because I've had 3, 4, 5 admits from a hospitalist. So they do like working with us, and they teach us the same too, which is great.
And just to kind of touch on what Jackson was saying there, like, I think it's really important to know whether or not you want to go into a program where your census is going to be 20 or 30 and you feel like you're constantly drowning and not learning. I feel like our census is much more manageable for an intern. I mean, the most I've carried is 4 by myself. So, even though that seems daunting, at least you have enough time to properly think through your assessment and plan. You're not just writing and copying and pasting and just like, oh my God, I got to hurry because I've got, 7 patients. Some of the programs I interviewed at, the census is we're running between 20 and 30, and I don't know how they do it. To be honest with you, but I think the ability to have a manageable census as an intern is really, really important, because you're just getting your feet wet, and then you can kind of grow from there once you jump into the senior.
Cool. Next question. Let me see. Does the program support new projects in the community in regards to chronic diseases? I feel like, do any of you guys have any input on that, interns?
So I know we haven't done anything as of yet, but I think that's one of the great things about being part of the Medical College of Wisconsin is the resources are there if you have an idea, and they will support that idea. I mean, I already kind of know where I want to go with my QI project as far as pediatric diabetes education to allow the pre-diabetic age that realm to be able to go there. So I mean, I've already talked to the staff, and they're already 100% okay with going that route. So the resources are available because we are a part of MCW, which is a huge hub. It's a massive campus with a lot of resources. So it's really, really amazing in that sense.
Cool. So like some of the programs that we've done in the past, chronic diseases, diabetes is like one of the biggest ones. I want to say if you come to us, 95% of your patients are going to be diabetic. Last year's chief resident, Dr. Aubrey Reefy, like I said earlier, she kind of put together a diabetes like fair where she had many people come in, including pharmaceutical reps, to talk about the diabetic patients. So one of the new biggest things is one of those like diabetic monitors where the patients don't have to poke themselves. All they have to do is like wave their phone to it and it'll give them a reading. She had the manufacturer of that come in and like talk to patients about it. We had a lot of educational, like a lot of community members, like church community members come in. Nurse Jenny and Nurse Lynette are two of the RNs that work at our program, and they are our diabetic educators, and they're great for what they do. We also have a PharmD on staff. So if you feel like the medication list is getting a little bit too long, whether it's hypertension, hyperlipidemia, diabetes, you can set up an appointment with the PharmD, Dr. Ombengi, and he'll go through the patient's list and like knock out things that they don't need or find ways to like better fit medication compliance. And it's not really a non-compliant issue. It's just that I have 20 meds and I forget this one or this one. And he'll help you kind of knock it down to maybe 15 or 14, which is still a lot, but it's still better than 20, you know. So, and Dr. Helm, who's our program director, if you want to do any project at all, for the most part, she's like, have at it. And you talk to Nurse Jenny and Dr. McKinney, who is the head of the community projects, and they'll help you make it happen. Next, what is the structure of the evaluation? So just to let you guys know, the interns haven't been officially evaluated yet because evaluations happen every 6 months. So midway during your year and then at the end of your year. But I'll let the interns talk about that.
Yes, I think the great thing about the program is weekly, no matter what rotation you're in, you sit down with the attending physician and you get feedback from your attending, you get feedback from your residents. And then I just finished my first rotation of inpatient medicine. And then you do evaluations of your fellow team members at that point too. So there's a constant state of, hey, you're doing this great, or hey, you can work a little bit better on that. And it's not in a critical manner. It's always to help you grow, which I think is great because on a weekly basis, you can improve as a doctor on what you're doing to make the team a better run, as well as make things easier for everybody else.
Just talking a little bit about that. Usually when I am on service, I'm the senior on service, I like to do Feedback Friday because there's no point in giving you feedback after everything is done because it would have helped like 3 weeks ago. So I like to sit down with the intern, give them a little bit of feedback, tell them what they're doing great, tell them what they're doing bad, and then get feedback myself because everyone learns in a different style. Like, do you want me to be more helicoptery or do you want me to back off? So it's always nice to know, and we are open enough to accept that feedback. Same thing with the interns, or I'm sorry, not the interns, the attendings. I like to ask the attendings to give me feedback, to give the interns feedback so they can grow from it. That's just how I do it. And then, yeah.
Yeah, I agree. I think feedback is kind of a two-way street. I think if you go asking for it, you're going to get it. And even when you're not asking for it, you're going to get it. But I think that this is a culture that values feedback, and I don't know. I appreciate that about it. Lack of feedback is stressful. Whether it's, whether you're not getting negative or positive feedback, I think that that's worse than not receiving any feedback at all. So that's something that I'm noticing, is that this is a culture of, this is what you're doing and this is how we can improve, and this is what you're doing well, and keep it up. So I think it's tangible.
I also agree. I think that like even throughout this rotation that I'm in, inpatient, gotten lots of feedback, but also practical ways that I could improve, like whether it's like, working on notes with the senior, or like learning how to make improving assessments and plans, like even like very specific practical things, and working through that, figuring out plans on how I can get better at those things has definitely been really great.
Cool. So time's running short, so I'm going to skip a few questions. I'm going to jump to the ones that are more intern specific. So what is a typical day like for an intern in the first few months?
I think it really depends on the rotation. I was just at Children's Hospital last month. So basically going in early, seeing all my patients, coming up with a plan for the day, rounding with the team. And like Jackson said earlier, at Children's Hospital, we really, you're pretty much a peds intern there. So you were doing everything, basically the exact same thing as them. Figuring out what to do for the day, then presenting, then, putting in orders and doing patient care throughout the rest of the day. Here in an inpatient at St. Joe's, it's pretty similar. Just coming in, making sure you see like your patients, writing your notes, coming up with your plans, and then, going out and doing patient care throughout the day. Yeah, that's what my typical day is.
Yeah, so we both started in inpatient medicine, what Wallace is on now. And yeah, that's pretty much what it looks like. You come in early in the morning to see your patients, do your notes. So we have a morning meeting then at 8 a.m. where you present all your patients and discuss what you'd like to do with them and kind of what's going on with them. And then throughout the afternoon, that's when you call consults or any other internal medicine hospitalists that you're consulting with or working with, and just kind of depending on what's going on with the patient, you go through things. Right now I'm on OB. It's a little different. We are with the OB/GYN residents, so learning from them and doing deliveries. So it's different. It's not as structured as what we have, but I kind of follow along with them. And you're right now, what are you on right now?
So right now I'm on pediatrics. So essentially what I'll do in the morning, I'll come in, go to the board, check to see what babies, newborns that I'll be taking care of for the day. Very similar. You write your notes, do your physical examinations. The cool thing about pediatrics is not only you getting the experience of being a part of that learning process, but you get to sit in on the actual inpatient team rounds. So you're constantly learning and growing and getting that inpatient experience. And then I usually get done at the hospital around 11 a.m. And then I'll jump to the clinic on my clinic days and do 1 to 5. So essentially the way the clinic works is you have 1 hour for each patient, which is really, really important as an intern to be able to have that time to navigate the system, really feel like you can properly assess the patient in the outpatient setting. And then you usually get done around 5 o'clock, and then I'll go back to the house and eat some food with my wife.
Yeah, so we try to structure your intern year with like intensive rotation with a non-intensive rotation. So your intensive ones are your inpatient. So 4 adult medicine rotations, 1 pediatric inpatient rotation. And I like to think OB is a little bit more intensive, and that's only because OB is my least favorite thing to do. But in between, we'll have not easier, but like rotations where you can catch a breather. Like Charles said, pediatrics is great for learning. And one of the best things I felt as an intern is that I would do my pediatrics and then I would present. I would get all the learning, but not be in the hot seat, you know, because like the inpatient interns have to present their present their patient, their assessment and plan, and you kind of get anxious because you're in the hot seat. Whereas a pediatrics, you're like, okay, I see where you're going. You're never pimped out as much as the inpatient intern is, but you're still learning. So yeah, we try to make sure you have a little break. The only exception to that is you might get children's inpatient and one adult inpatient back to back, and that's just because of how scheduling is. So after those 2 months, a nice little rotation that is a break is much appreciated. And then just, I don't know if you guys were curious about like time for inpatient. The day intern works from 7 a.m. to 7:30 p.m. officially, but you come in as early as you need to finish your chart by 8 a.m. because that's when we round. You have to be done by 8. And then the night intern works from 7:30 p.m. to 9:30 a.m. And we try to get you out by 9:30 because we have duty hours. So you need your 10 hours of rest in between before you can come back for a shift. If it's
Yeah, and the
busy,
big thing is like they are 100% like the 9:30. If you're the night intern, you're leaving. Like it doesn't matter if you're not done, you haven't staff. Like they get you out the door. So there isn't that like, oh my God, I've been here, you know, over hours. It never happens. Like it's all the way from the seniors to the attendings. They're all really adamant about that. So it does feel good that even if you hadn't finished all your tasks for that day, which obviously hopefully you do, you know, they'll pick up the slack in the day team and make sure you get out and get some good sleep.
Yeah, and actually, I stayed like 15 minutes later, and which is not a big deal. But then they told me to come back in 15 minutes late. So
yeah,
like when I would come in. So everyone's always really aware of like when you're leaving, when you're coming and stuff, and they're really good about it. So never had problems with that so far.
Cool. Let's see what else. Teaching opportunities for residents. And I'll let you guys take care of that, interns.
Yeah, so I mean, I think that the big thing that we do in the program is throughout the week, on at least I've seen it on inpatient, you'll be given a specific topic that wants to be lectured on, and you just present a 5 or 10 minute topic, presentation on a topic, and it's really nice because you obviously you spend a little bit more time preparing that, but it really allows you to. The most recent one that I did was on uncomplicated gastroesophageal reflux in newborns. So I just put together a nice presentation, and it really gave me a better understanding of how to work that up in the outpatient or inpatient setting. And that learning, I think that's one of the big things I really love here is that there's not too many questions you can ask. There's not enough information that you can get from people. It's not like, oh my God, this is your 10th question today. Come on, bro. Like it's like, hey, okay, cool. Let me help you. Like this is how I usually work through it. So I think that open nature of constantly wanting to grow as a doctor is cultivated in this program.
And if you like teaching, albeit it's our second month, but we did have 2 sub-Is.
Yeah.
And you would get to interact with them. And then if there's anything that you feel like you can teach, like you be a teacher, then you have that opportunity as well as an intern to interact with them and help out.
Yeah, so as a second and a third year, you'll have a medical student with you. And so you get to teach them as they work with you and kind of help improve their efficiency, their family medicine knowledge, things like that. You have the sub-I, and then everybody has to do a grand rounds, which is about an hour presentation on anything that you want to choose. And you present that to everybody in the residency, the faculty and the residents. Things that have been done there's some more traditional ones like, diabetes management, hypertension management, inpatient medicine. We've had some residents go off and do a little bit more outside the box things, like somebody did euthanasia, somebody did how to navigate the insurance like problems that we have. One of them also did like a little bit more businessy aspect about how to save up money during residency, whether you should pay back debt or buy that new Tesla as soon as you finish, things like that. So pretty much anything that can be applied to family medicine, you can present on. And as you guys know, family medicine is huge because you can easily go into administration. So we've had some things like that. You can just be a like boots on the ground type of doctor, or so, or diabetes and things like that. And,
Jackson,
yes.
can we just maybe do one more question just to respect everybody's time so they can get back to wherever they need to for 1 o'clock?
Sure. I feel
Thank
like this is a big one. If you had to improve one aspect of the program, what would you improve? So, interns?
I don't know how this is going to sound to you guys, but I honestly wouldn't change anything. This program, I know when you like read about it and you hear about it, it sounds like it's too good to be true. And it's amazing here. So I don't think I would change anything, to be honest. I don't know what I would change. I love everything. And I'm not just saying that because I'm here. It's true.
Yeah, I mean, this was my dream program. Like, there wasn't
Yeah.
even a program that was anywhere in the stratosphere as far as when I ranked. And like, I literally remember getting the match thing in Target. Me and my wife started like screaming and like crying, literally, because it was like so amazing to be able to know you're going somewhere that not only you appreciated, you're cared about. It's a great feeling. I mean, you enjoy going to work. I mean, whereas, if you were in a program where you didn't feel valued, it would suck. Let's just be honest. It would be really bad, that go through 3 years of really put in a lot of work and trying to grow as a doctor and not feel happy doing that and getting the reward from not only just the patients in the community, but from your own program.
One of the things that I would change is that we have a EMR in our clinic that is different than the one in our hospital. It's called NextGen, and the one in the hospital is called Epic. And I don't know if I'm like, I don't know, maybe electronics are hard for me, but I wish I only had one to learn instead of two. And I'm always asking questions about how to do stuff, and I feel like I'm annoying. So I think it'd be easier if there was just one EMR. Yeah.
Yeah, I take back my statement. I agree with Tom for sure. Next gen. Yep.
Yeah, I definitely agree. Next gen sucks. Epic is awesome. We are supposed to be getting it soon, so we'll see. And Julie, please don't hurt me for this, but one of the biggest things that I really dislike about our program is some of the rotations are more shadowing than actual hands-on. For instance, dermatology, he was a great doc. He taught me a lot, but when he did a Mohs, I kind of just stood there and watched. Or when he did an excision or a Botox injection, I kind of just stood there and watched. I would have liked to be more hands-on, but it might have been that he was in a nicer part of town. So take that how you may. Some people may not just want a resident touching or things like that. Or for instance, surgery. There were times when you would go in the surgery with them, but you're not a surgical resident. So yeah, you're not like first, doing everything. So they would let me close up with a suture or something like that. But there are just some rotations I wish were a little bit more hands-on.
I'm just going to quick interject regarding the EMR. We are scheduled to get Epic here, but because COVID happened, it did postpone it a little bit, just so you know. Sorry. And I have somebody in my office. That's why I have my mask. So just to respect everybody's time, we went 3 minutes over. We did record this, so we are going to be putting this up on our website if you wanted to go back and re-listen to anything. We are going to have another one next week. I don't know the exact date, but we do have one scheduled for next week as well. So definitely tune in. If you do have other questions that you did want answers to, feel free to email me, and we can get those questions answered for you. But I just wanted to thank everybody for their time and coming out and joining us for this Q&A session with the interns.
Yeah, thanks so much, guys.
Thanks, guys.
It means a lot.
Thank you.
You took the time to actually, care about our program. And through Julie, if you want to reach out to me and have any questions as far as, running through interviews or how the whole process is going to go with match or, more about our program, don't hesitate to ask. I'm here, and hope you guys have a great day.
Yes, and just so everybody does know, we will be doing all of our interviews virtually this year. So you will probably be able to look at a book, but just virtually. So thank you, everybody. I appreciate your time.
Yep. Take care, everybody. Best of luck.
All the best.
Yep.
Thank you.
Yep.